hypertriglyceridemia. So the etiology, it is caused by genetic factors, familial hypertriglyceridemia, secondary to acquired disease like diabetes mellitus, obesity, hypothyroidism, nephrotic syndrome, and alcohol abuse. It may happen as an adverse effect to some medications like tamoxifen, beta blockers, corticosteroids, and antiretrovirals. We have talked about how beta blockers cause weight gain. Um so basically, that the beta blockers decrease because they cause vasodilation. Beta blockers. No, actually, they just decrease the glucose uptake by the tissues, and increased glucose will be circulating into the circulation that will lead to increased insulin release, and that increased release will lead to lipogenesis, and that will lead to increased weight gain. So, increased triglyceride levels can cause increase in the following disease. More than 150 milligram per deciliter will lead to an increased risk of cardiovascular events, and triglyceride level more than 1000 milligram per deciliter will lead to an increased risk of pancreatitis. Management: mild to moderate hypertriglyceridemia 150 to 500 milligram per deciliter. High intensity statin at the first line. Then lifestyle modification like weight loss, increased exercise, moderate alcohol intake. That is 2 drinks per day for a male and 1 drink per day for a female. So treatment of hypertriglyceridemia. Hypertriglyceridemia firstly evaluate for secondary causes. If the triglyceride level is 150 to 500 milligram per deciliter, go for lifestyle modification with weight loss, moderate alcohol intake, and increased exercise. Non-cardiovascular disease or high risk, start the statin therapy. If it is more than 1000 milligram per deciliter, initial goal is pancreatitis prevention like fibrates, fish oil, and abstinence from alcohol. And once the level reaches less than 500 milligram per deciliter, then come back to this one, like lifestyle modification, and for the non-cardiovascular disease or high risk, start the statin therapy. The next is indications for statin therapy. So for secondary prevention and primary prevention. Secondary prevention of Secondary prevention can be established for the established atherosclerotic cardiovascular disease, acute coronary syndrome, stable angina, arterial revascularization like cabbage, and stroke, transient ischemic attack, and peripheral artery disease. Primary prevention is for the people with an LDL of more than 190 milligram per deciliter, age more than 40 with diabetes mellitus, and estimated 10-year risk of atherosclerotic cardiovascular disease of more than 7.5% to 10%. Uh, yes, and the statin therapy is a part of Monabash, like the S is for statins. Then we have guidelines for the statin therapy. Indications: the clinically significant atherosclerotic cardiovascular disease, acute coronary syndrome, stable angina, arterial revascularization like cabbage, stroke, transient ischemic attack, and peripheral artery disease. Recommended therapy for the age less than 75, high intensity statin, and age more than 75, moderate intensity statin should be started. LDL more than 190 milligram per deciliter, we should start with high intensity statin. Age 40 to 75 with diabetes, 10 years atherosclerotic cardiovascular disease risk of more than 7.5%, we should start high intensity statin, and 10-year atherosclerotic cardiovascular disease risk less than 7.5%, moderate intensity statin should be started. Then estimated 10-year atherosclerotic cardiovascular disease more than 7.5%, pooled cohort equation, moderate to high intensity statin should be given. High intensity statin include atorvastatin 40 to 80 milligram, rosuvastatin 20 to 40 milligram. Moderate intensity statin include atorvastatin 10 to 20 milligram, rosuvastatin 5 to 10 milligram, and simvastatin 20 to 40 milligram, pravastatin 40 to 80 milligram, and lovastatin 40 milligram. Okay. Then muscle injury due to statins. So muscle injury is an adverse effect of statin therapy. Statin cause myopathy via decreased coenzyme Q10 synthesis that will lead to decreased energy production, and that will lead to myopathy. This was tested in Uworld question. So statin can lead to muscle injury, for example, myalgia and myonecrosis. Deciding what to do when a patient develops myopathy depends on the severity of the myopathy. If the patient develops rhabdomyolysis, discontinue statins entirely. If the patient develops mild myopathy, then switch to a different statin. Subclinical hypothyroidism and statin-induced myopathy. Subclinical hypothyroidism is associated with an increased risk of statin myopathy. Many experts advise measuring a serum TSH level before starting the statins or when side effects occur in patients receiving the treatment. Lipid panel screening. It is divided into first screening and repeat screening. First screening at the time of initiation of care with an adult primary care practitioner if patients haven't been screened as children. Uh, then we have repeat screening. So the repeat screening is based on the patient's cardiovascular risk. High cardiovascular risk, males 20 to 30, 25 to 30 years and females 30 to 35 years. The low cardiovascular risk is for the males more than 35 years and females more than 45 years. Then comes the cardiovascular risk management in the diabetes mellitus type 2. The general measures are healthy weight, exercise and smoking cessation. The blood pressure include medication with lifestyle measures to initial target of less than 140 by 90 millimeters of mercury and continue measures to target of less than 120 by 80 if possible. Cholesterol. High intensity statin established cardiovascular disease or 10 years CVD risk more than 20%. Moderate intensity statin, all other patients age more than 40. So atorvastatin, high intensity statin, atorvastatin 40 to 80 and rosuvastatin 20 to 40 milligram daily. And moderate intensity statin is atorvastatin 10 to 20 and rosuvastatin 5 to 10 and simvastatin 20 to 40 milligram and rovastatin 40 to 80 milligram. Lovastatin 40, fluvastatin 80 and pitavastatin 2 to 4 milligram daily. Okay. So here comes the adverse effects of niacin. Adverse effects include cutaneous flushing, intense generalized pruritus. These side effects occur due to the high dose niacin. High dose is required to treat lipid abnormalities. Mechanism: drug-induced release of histamine and prostaglandins. Prevention: low dose aspirin taken 30 minutes before niacin. So, core pulmonary etiology: COPD and pulmonary embolism. Core pulmonary develops due to pulmonary hypertension. Features of pulmonary hypertension are widely split S2 and increased intensity of the pulmonary component of S2. Characteristic findings of core pulmonary: the common etiologies include COPD, which is most common, interstitial lung disease, pulmonary vascular disease, for example, thromboembolic, and obstructive sleep apnea. Symptoms: dyspnea on exertion, fatigue, and lethargy, exertional syncope due to decreased cardiac output, and exertional angina due to increased myocardial demand. Examination: on examination, there will be peripheral edema, increased regular venous pressure with prominent A wave, loud S2, right-sided heave, pulsatile liver from congestion, tricuspid regurgitation murmur. Imaging: ECG will show partial or complete right bundle branch block, right axis deviation, right ventricular hypertrophy, right atrial enlargement. Echocardiogram will show pulmonary hypertension, dilated right ventricle, and tricuspid regurgitation. The right heart catheterization is a gold standard for diagnosis, showing right ventricle dysfunction, pulmonary hypertension, and no left heart disease. Pulmonary hypertension, it is defined as mean pulmonary artery pressure of more than 25 millimeters of mercury at rest. Normal is less than 20 millimeters of mercury. If it is more than 25, then it is pulmonary hypertension. Management: pulmonary hypertension due to left ventricular systolic dysfunction, loop diuretics and ACE inhibitors, PH due to COPD, pulmonary hypertension due to COPD. So, if it is due to left ventricular dysfunction, so we treat it the way we treat the congestive heart failure, like loop diuretics and ACE inhibitors. If it is due to COPD, then we give oxygen and bronchodilators. If it is due to idiopathic causes, then endothelin receptor antagonists like bosentan and phosphodiesterase E5 inhibitor like sildenafil and prostanoids like epoprostenol, and PH due to chronic thromboembolic occlusion of the pulmonary vasculature, long-term anticoagulation. The clinical features of pulmonary hypertension classification: pulmonary hypertension WHO group 1, due to left-sided heart disease group 2, due to chronic lung disease COPD interstitial lung disease group 3, due to chronic thromboembolic disease group 4, and due to other causes sarcoidosis group 5. So these are the causes of pulmonary hypertension. Pulmonary arterial hypertension due to left-sided heart failure, due to chronic lung disease, due to chronic thromboembolic disease, and due to other causes. So these are 5 groups. System symptoms: dyspnea, fatigue, weakness, exertional angina and syncope, abdominal distension and pain. Signs: left parasternal, left and right ventricular heave, loud P2, right-sided S3, pan-systolic murmur or tricuspid regurgitation, JVD, ascites, peripheral edema, and hepatomegaly. Persistent pulmonary hypertension of newborn. So the pathogenesis is abnormal persistence of elevated fetal pulmonary vascular resistance. You know that the children have high pulmonary vascular resistance due to collapsed lungs. If it persists, it is called as persistent pulmonary hypertension of the newborn. Right to left shunting across the ductus arteriosus. With respect to the lung hyperplasia, for example, congenital diaphragmatic hernia, meconium aspiration syndrome, infection, for example, neonatal pneumonia, examination will show decreased post-ductal relative to pre-ductal oxygen saturation, respiratory distress and cyanosis, and prominent S2. Treatment is oxygenation and ventilation and inhaled nitric oxide pulmonary vasodilator. Tricuspid valve endocarditis. Its risk increases due to IV drug abuse. It leads to septic emboli to the lungs which present as cough, chest pain, and hemoptysis. The diagnosis is X-ray CT scan, numerous round alveolar infiltrates. Tricuspid regurgitation is common complication of tricuspid valve endocarditis. It causes hollow systolic murmur which increases on aspiration. So the most important thing that you must remember about tricuspid regurgitation is that it increases with inspiration. This is the way we differentiate tricuspid regurgitation from mitral regurgitation, which does not have any change on the inspiration or expiration. Then comes aspirated systolic hypertension. It is defined as systolic blood pressure of more than 140 millimeters of mercury, with a diastolic blood pressure of less than 90 millimeters of mercury. It is associated with increased risk of cardiovascular morbidity and mortality. It is common in elderly patients. Like the systolic blood pressure is more than 140 while the diastolic is normal. The pathophysiology is that there is increased stiffness of aorta and arterial walls and decreased elasticity of aortic and arterial walls. So basically, whenever the systolic blood enters the arteries, there is a systolic pulse that causes the vessels to become distended for a while, right? So this distension of the vessels causes the pressure to be equally divided among the larger area, so the pressure is not very much elevated. But if the walls are stiff and the elastic recoil of artery is not happening, so resultantly, what are we expecting to see is that the systolic blood pressure will start rising while diastolic will be normal. So it is managed the same way as the primary hypertension. Other causes of isolated systolic hypertension are hyperdynamic states like anemia, hyperthyroidism, AV fistula, beriberi, and Paget's disease. Hyperdynamic states present with a ventricular heave or hyperdynamic precordium on physical examination. They can lead to high output cardiac failure. High output cardiac failure, the features are widened pulse pressure, strong peripheral arterial perfusion, systolic flow murmur, tachycardia, and flushed extremities. On ECG, we will find left ventricular hypertrophy. Causes are patent ductus arteriosus, trauma. For angiomas, just give me a second. We are talking about high output cardiac failure. So the patent ductus arteriosus, I'm sorry, these are not, equal terms. These are the congenital causes include patent ductus arteriosus, angioma, pulmonary AV fistula, and is that fistula? AVF. I think it is fistula. Pulmonary AV fistula and CNS AV fistula. Acquired causes include trauma, iatrogenic like femoral catheterization, atherosclerosis, for example, aortocaval fistula, and cancer. So in high output cardiac failure, the problem is at which point? Primary disturbance is that there is decreased systemic vascular resistance like AV fistula that decreases the systemic vascular resistance and increases the cardiac output. Also, it increases the central venous pressure and increases the pulmonary capillary wedge pressure. So decreased systemic vascular resistance increases the central venous pressure and that increases the pulmonary capillary wedge pressure as well. Yes, because there is increased preload because of visual formation. Yes. Then we have general manifestations of hyperthyroidism. Symptoms: anxiety and insomnia, palpitations, heat intolerance, increased perspiration, weight loss without decreased appetite. Physical examination include goiter, hypertension, tremors involving fingers, hands, hyperreflexia, proximal muscle weakness, lid lag, and atrial fibrillation. Stent thrombosis, it is a fatal complication of coronary artery stenting. Prevention: dual antiplatelet therapy, aspirin, platelet P2 wide valve receptor blocker like clopidogrel, prasugrel, and ticagrelor. Guidelines state that after stent placement, dual antiplatelet therapy should be continued for some time. The specific guidelines for it are written below. Intracarotid stent, that is dual antiplatelet therapy for 12 months. Only angioplasty, no therapy is needed. So for stent thrombosis, we have to give dual antiplatelet therapy for 12 months and only angiotherapy. If we have done only angiotherapy, then no therapy is required. Premature discontinuation of antiplatelet therapy is the strongest predictor of stent thrombosis within first 12 months. The left ventricular aneurysm, it looks like this on ECG. On ECG, persistent ST elevation along with evidence of prior MI, deep Q waves, which is an indication of previous MI, and T wave inversion. Now here you can see that there is persistent ST elevation. Here you can see it. Here you can see it. There it is. And I guess in this lead V1 we can also find ST elevation. So there is persistent ST segment elevation. Then there is pathologic Q waves which are present, and along with Q waves we can also find the T wave inversion. Okay, where is inverted T wave? Where is Q wave? I can't locate them on the ECG strip, but they are present because these are characteristics of the previous MI. So it represents scarred or fibrotic myocardium as a result of prior transmural myocardial infarction a few months old. Presentation is heart failure due to left ventricular enlargement. Now it is a time when the scar has formed. It cannot undergo rupture, but it can dilate, so it can form aneurysm. There will be refractory angina. Very important ventricular arrhythmias. It may lead to sudden cardiac arrest. Systemic arterial embolization due to mural thrombus. ECG findings are as discussed before. Left ventricular aneurysm, the etiology is scar tissue deposition following the transmural MI. The clinical presentation several months following MI, heart failure and angina. Ventricular arrhythmias, for example, ventricular tachycardia and systemic embolization like stroke. Diagnosis on ECG, there will be persistent ST elevation and deep Q waves. Echocardiography will show thin and dyskinetic myocardial wall. Then comes the Q waves. Normal Q waves, small Q waves are normal in most leads. Deeper Q wave, that is more than 2 millimeters, may be seen in the leads 3 and AVR as a normal variant. Abnormal Q waves are more than 40 millisecond wide, that is 1 millimeter wide, more than 2 millimeter deep. But if they are in lead 3 and AVR, they can be normal. Otherwise, more than 2 millimeters is pathological. More than 25% of depth of QRS complex, this is QRS complex, right? So, like if this is the height, so the Q wave must not be more than 25% of its length or its height. So, seen in lead V1 to V3. Abnormal Q1 waves are present in lead V1 and V3. Then he has sudden cardiac arrest with prior MI history. Risk of sudden cardiac death increases in patients with a prior MI history complicated by left ventricular systolic dysfunction with ejection fraction of less than 30%. Sudden cardiac death in majority of the cases is due to ventricular arrhythmias. Systolic dysfunction is normally prevented by MI by prescribing the medications that stop the cardiac remodeling. ACE inhibitors, beta blockers, and spironolactone. However, if ejection fraction is persistently less than 30%, it increases the risk of sudden cardiac death anyway. Management is implantable cardioverter defibrillator (ICD). Left ventricular thrombus. Patients with large ST segment elevation MI are at an increased risk of left ventricular thrombus and anteroapical aneurysmal formation. Such patients often have left ventricular ejection fraction of less than 40%. Complications: systemic embolization, which can cause stroke and peripheral heart disease. Then comes the management. So immediate anticoagulation and transthoracic echocardiogram with echo contrast. Now coarctation of aorta. There are certain signs which are very important. A classic 3 signs of coarctation is present. There will be rib notching from the dilated intercostal arteries. Aortic coarctation and pre-stenotic dilation creates the 3 sign. Coarctation of aorta. The pathology. Thickening of tunica media of the aortic arch can be associated with the Turner syndrome or bicuspid aortic valve. The clinical features: increased blood pressure and strong pulses in the upper extremities, decreased blood pressure and weak pulses in the lower extremities. Neonates will show severe narrowing, heart failure, for example, poor feeding and diaphoresis, and cardiogenic shock. Children and adults will with mild narrowing, will show lower extremity claudication, palpable pulsations of the intercostal vessels of the collaterals, and secondary hypertension in the upper arms. Complications include aortic aneurysm and dissection and rupture, cerebral aneurysm and subarachnoid hemorrhage. Treatment is prostaglandin E1 for the neonates with severe narrowing and surgical repair. It is associated with rib notching on chest X-ray due to the enlarged collateral vessels. Uh, the presentation is brachiofemoral pulse delay, high blood pressure in both arms compared to the lower extremities, and continuous machinery murmur over the back, difficult to auscultate in supine position. So how does the collateral forms? Like suppose this is the okay, just give me a second. Suppose that here we have the aorta and there is a coaptation and it goes like this, and here we have a patent arteriosus, that is it is a post-rectal kind of coaptation, and subclavian arteries over here. Now subclavian artery give rise to a branch which is internal thoracic artery. This internal thoracic artery is connected with the anterior intercostal arteries. Anterior intercostal arteries send the blood into the posterior circulating arteries, which can bring blood back to the aorta. Now, normally the aorta is moving downwards and the blood is moving from the aorta into the posterior intercostal arteries. But in these situations, when aorta does not have enough blood, so a retrograde pathway is established that the blood is moving from the anterior to the posterior and back to aorta and then to the lower extremities. So this is how the collaterals are developed, and they can cause the erosion of lower aspects of the ribs, because these vascular bundles are present in the lower ribs, on the lower side of the ribs. So that will produce a characteristic rib notching, and then we have brachiofemoral delay, high blood pressure both upper arms compared to the lower extremities, and continuous machinery murmur of the back, which is difficult to auscultate in the supine position. So it is basically a diagram in which they are depicting the patent rectus arteriosus. Aortic coaptation can present with acute heart failure and cardiogenic shock upon closure of the rectus arteriosus. Administration of prostaglandin E1 maintains the ductal patency, which restores the systemic blood flow by shunting the blood from the pulmonary artery to the aorta, that is right to left. It's still systemic blood flow, not pulmonary blood flow, as it hasn't reached the lungs yet. Got you with that choice. What? Administer prostaglandin to maintain the ductal patency, which restores the systemic blood flow by shunting blood from the pulmonary artery to the aorta. So it is basically systemic blood that is reaching the aorta through the patent rectus arteriosus. Coarctation of aorta etiology, it is congenital or acquired in the cases of Takayasu arthritis. The clinical features: upper body will have well developed, upper body will be well developed in child, the upper body will be well developed. There will be hypertension, headache, and epistaxis. Lower extremities will be underdeveloped with claudications. Brachiofemoral pulse delay will be present. Upper and lower extremity there will be blood pressure differential. Left interscapular systolic or continuous murmur. Diagnostic signs: ECG will show left ventricular hypertrophy. Chest X-ray will show inferior notching of the third to eighth rib. 3 sign due to aortic indentation. Echocardiography is diagnostic and confirmatory. Okay. Treatment is balloon angioplasty with or without stent placement and surgery. Then, so in this diagram, we can see that this is brachiocephalic artery, this is the pulmonary artery. So the point is that this is the patent rectus arteriosus, and the coaptation is before that, so it is preductal kind of coaptation. In the second picture, you can see that in this given scenario, it is the pulmonary artery which is supplying the blood to the descending aorta through the ductus arteriosus. But when the ductus arteriosus closes and becomes ligamentum arteriosum, the blood flow to the descending aorta is very limited due to the coaptation. Then we have the next topic, that is extra effects of RAS activation, renin-angiotensin aldosterone system activation. Now this system is activated whenever there is a decreased blood pressure, so it causes vasoconstriction and salt and water retention. Vasoconstriction of both afferent and efferent glomerular arterioles, which leads to increased vascular resistance and decreased renal blood flow. Preferential vasoconstriction of efferent arterioles, which leads to increased intraglomerular pressure to maintain the GFR. Direct stimulation of sodium reabsorption in the proximal tubules. Increased secretion of aldosterone and increased sodium reabsorption in the cortical collecting tubule. The net result will be increased blood pressure, increased total body sodium and water, and increased blood volume. Hence, any drug that inhibits the RAS system will lead to increased natriuresis and decreased blood pressure. Now, here is the flow sheet diagram. Here you can see that it is the juxtaglomerular apparatus of the kidney that produces renin, and renin then causes the conversion of angiotensinogen to angiotensin 1, which is converted to angiotensin 2 by the action of angiotensin converting enzyme in the pulmonary capillary endothelium. And this angiotensin converting enzyme also converts the bradykinin into inactivated products. The angiotensin 2 acts on the vascular bed. Angiotensin 2 receptor type 1 on so it acts on the angiotensin 2 receptor type 1 in the vascular beds, causing vasoconstriction, and that will cause hypertension. And also on angiotensin 2 receptor type 1 on the adrenal cortex. From there it releases aldosterone. Aldosterone acts on the principal cells of nephron, specifically on the mineralocorticoid receptors, and they cause sodium reabsorption, and that also causes hypertension. Now there are certain drugs systems which affect this process. Beta blockers, these are drugs, I'm sorry. The beta blockers inhibits the sympathetic activation by the beta 1 receptors of the juxtaglomerular apparatus, so the renin itself is not produced. The renin can also be inhibited by the direct renin inhibitor like aliskiren. Then ACE inhibitors can inhibit the angiotensin converting enzyme. Thus, the conversion of angiotensin 1 to angiotensin 2 and bradykinin to inactivated products is inhibited. Angiotensin 2 receptor blockers can cause the inhibition of do not allow the angiotensin 2 to cause vasoconstriction and aldosterone release. Mineralocorticoid receptor antagonist like spironolactone inhibits the aldosterone's downstream effects, and the hypertension. So basically, juxtaglomerular apparatus are stimulated by the beta 1 sympathetic stimulation, and also by the low blood flow to the kidneys like hypotension, renal artery stenosis, or diuretic use. And whenever there is hypertension, there is negative feedback and on this, and then renal release cannot happen. The next thing is best indicator for the heart failure. It is BNP. BNP is the best indicator for the heart failure. Its level become more than 400 picogram per ml in congestive heart failure. BNP is produced by the cleavage of pro-BNP. The cleavage results in the production of BNP and inert N-terminal pro-BNP, NT-pro-BNP. BNP and N-terminal pro-BNP are highly suggestive of left ventricular systolic dysfunction. Conversely, normal values have a very high negative predictive value of congestive heart failure. Hence, non-cardiac causes should be explored if BNP is normal. Normal changes in aging heart, decreased resting and maximum cardiac output, decreased maximum heart rate, decreased myocyte number, increased contraction and relaxation time of the heart muscle, increased myocardial stiffness during diastole, and pigment accumulation in the myocardial cells. All of that is happening in the aging heart. Then we have scleroderma renal crisis. It can occur in a few patients with diffuse cutaneous systemic sclerosis. It occurs within first 5 years of systemic sclerosis diagnosis. Pathophysiology: increased vascular permeability, activation of coagulation cascade, and increased renin secretion. Presentation: sudden onset renal failure without previous kidney disease and malignant hypertension. On labs, the peripheral blood smear will show microangiopathic hemolytic anemia and schistocytes are seen, and will get the findings of disseminated intravascular coagulation in systemic scleroderma renal crisis. Other RBC shapes include Burr cells, also called as echinocytes. Appearance is spiculated appearance RBCs with serrated edges, and they are associated with liver disease and end-stage renal disease. So these are echinocytes or Burr cells, as you can see in these pictures. So they are associated with the liver disease and end-stage renal disease. Then comes the Howell-Jolly bodies. They are present in the people who have splenectomy. Appearance of basophilic remnants of the nucleus that appears as small black pellet in the RBCs. Association of splenectomy and functional asplenia like in the people with the sickle cell disease. Then we have spur cells like this. So these spur cells are also called as acanthocytes. RBC with irregularly sized and spaced projections. associated is liver cell. Okay, then we have the next thing, that is um, target cells. So this is a target cell, like the target of an arrow. Appearance RBC with central density surrounded by the pallor, bull's eye appearance. Association is thalassemia and chronic liver disease, especially obstructive liver disease. Hepatojugular reflux. Hepatojugular reflux is basically also called as the abdominal jugular reflux. It is elicited by applying firm and sustained pressure for 10 to 15 seconds over the upper abdomen. A positive response is sustained elevation of jugular venous pressure more than 3 cm during continued abdominal compression. It is seen in constrictive pericarditis, right ventricular infarction, restrictive cardiomyopathy, and cardiac tamponade. Autosomal dominant polycystic kidney disease. It is a condition in which we have uh, bilateral. I think bilateral kidneys are affected. So, but this is a condition. Okay, I'm not sure about bilateral kidneys. Yes, it is usually bilateral, and it is strongly associated with the subarachnoid hemorrhage because of the perianeurysm formation. It is most common genetic cause of chronic kidney disease. Pathophysiology: mutations in the PKD1 and PKD2, disruption of function of polycystin proteins leads to cystic degeneration of renal parenchyma. The presentation is age of presentation is 30 to 40 years. Hypertension, hematuria, nephrolithiasis, blank pain, UTIs, increased erythropoietin, and that will lead to increased hemoglobin. This is due to possible local ischemia around the renal cysts. The diagnosis is on the abdominal ultrasound and CT scan. Differentials: primary aldosteronism. It presents with unilateral abdominal mass which is not easily palpable. Instead of bilateral mass seen in autosomal dominant polycystic kidney disease. So the clinical presentation of ADPKD is most patients are asymptomatic until age of 30 to 40. Blank pain and hematuria, hypertension, palpable abdominal mass usually bilateral, and chronic kidney disease. Extrarenal features are cerebral aneurysm, hepatic and pancreatic cysts, mitral valve prolapse and aortic regurgitation, colonic diverticulosis, and ventral and inguinal hernias. Diagnosis: ultrasonography showing multiple renal cysts. Management is aggressive control of risk factor for uh, CV and CKD. What is CV? CV is what is CV? Okay, I don't know. What is CV? Cerebro. Okay, and CKD. CKD is chronic kidney disease. What is CV? Is inhibitor preferred for the hypertension and hemodialysis, renal transplant for end-stage renal disease. Then aortic dissection, acute aortic dissection. Here you can see that this is the aortic lumen. Then we have a flap, and then a second lumen is present. So this is aortic dissection as depicted on the CT. So it is divided into type A, which involves the ascending aorta, and type B, which involves the descending aorta. Okay. So it is the Stanford classification. Dissection of aorta, like type A is intimal tear, and this is these two are ascending aorta, and intimal tear, the one with the intimal tear involving the descending aorta, it is the type B. So according to the Baker system, this one in which both of these problems are present in one aorta is type 1. This is in which only ascending is involved, type 2, and only descending, type 3. So it goes like that. Now moving forward, we have presentation of the aortic dissection. So there will be sudden onset of severe chest or back pain that is sharp or tearing. Pleural pain may occur due to hemothorax and inflammatory reaction to the blood irritating the pleural lining. Lab studies will show increased D-dimer, sensitive but not specific. Acute anemia due to hemothorax. ECG findings depend on underlying comorbidities, for example, left ventricular hypertrophy and hypertension, and on whether the coronary ostia have been compromised. Complication of type A dissection is based on the vessels involved. Carotid arteries, if they are involved, that can lead to stroke. Coronary artery ostia, syncope, MI, and heart failure. Aortic root involvement will lead to regurgitant murmur. Diagnosis: firstly, we'll do the X-ray and we'll see a widened cardiac sellout. CT angiography, initial study of choice in the hemodynamically stable patient with no evidence of renal dysfunction. uh, on CT angiography, we will see intimal flap and double aortic lumen. MR angiography, more time consuming, requires administration of gadolinium contrast agents, which causes nephrogenic systemic fibrosis. Hence, it should be avoided in the patient with moderate to severe kidney disease. Intraoperative transesophageal echocardiography, it is preferred in the patient with hemodynamic instability or renal insufficiency. Treatment is immediate surgical repair for type A dissections and type B dissections, which are complicated by organ malperfusion. Type B dissections that do not result in the malperfusion of thoracic or abdominal organs can be managed by pain and blood pressure control. What is the diagnostic approach to suspected aortic aneurysm? So, if there is suspected aortic aneurysm, so firstly we look for the risk factor like Marfan syndrome, connective tissue disease, and hypertension, tearing chest pain or abdominal pain radiating to the back, perfusion deficits like pulse deficit more than 20 millimeters of mercury, blood pressure difference between right and left arm, and aortic regurgitation murmur. Chest X-ray ECG suggesting of other diagnosis. If yes, evaluate and treat properly. If no, then normal serum creatinine and no contrast allergy. If no, so if the serum creatinine and contrast allergy is present, if serum creatinine is elevated and the contrast allergy is there, so transesophageal echocardiogram is preferred. And if these things are, if the creat is normal and no allergy is present, then we can imaging based on availability like transesophageal echocardiogram, CT chest with contrast, and MRI only if non-emergency and patient can lie still. Acute aortic dissection. The clinical features are history of hypertension, Marfan syndrome, cocaine use, severe sharp tearing chest or back pain, plus minus more than 20 millimeters mercury variation in systolic blood pressure between the arms. Complications due to extension involved structures. Complication due to extension, the involved structures include stroke, that is carotid artery, acute aortic regurgitation, aortic root valve, Horn syndrome of carotid sympathetic plexuses are involved, myocardial ischemia and infarction, coronary artery ostium, pericardial effusion and tamponade, the pericardium, hemothorax, pleural cavity, renal failure, renal injury in renal arteries, abdominal pain in the mesenteric arteries, and lower extremity paraplegia in the spinal arteries. Then we have acute aortic dissection. So the clinical presentation: history of hypertension, genetic disorder like Marfan syndrome, severe sharp tearing chest or back pain, more than 20 millimeters of mercury difference in systolic blood pressure between the arms. The diagnosis is done with the ECG, normal or non-specific ST and T wave changes. Chest X-ray will show mediastinal widening, and CT angiography or transesophageal echocardiogram for the definitive diagnosis. The treatment is pain control, for example, morphine, intravenous beta blockers, for example, esmolol. With or without sodium nitroprusside, if systolic blood pressure is more than 120 millimeters of mercury, emergent surgical repair for the ascending dissection. Type A is considered a surgical emergency with mortality rates of 1 to 2% per hour following symptom onset. Goal of initial therapy are adequate pain control, reduction of systolic blood pressure to 100 to 120 millimeters of mercury, decrease in left ventricular contractility to reduce the aortic wall stress. IV beta blockers like labetalol, propranolol, esmolol are given to decrease the heart rate, systolic blood pressure, and left ventricular contractility. Our nitroprusside and hydralazine are not preferred as they are vasodilators and can cause reflex tachycardia. Nitroprusside can be used as second line agent only if systolic blood pressure remains above goal, that is more than 120 millimeters of mercury, despite adequate beta blockade. The next topic is peripartum cardiomyopathy. So last month of pregnancy to 5 months post pregnancy is the peripartum period. It is uncommon. It is an uncommon dilated cardiomyopathy that develops in following periods: last month of pregnancy and within 5 months following surgery. It is often associated with mitral regurgitation. The diagnosis is transthoracic echocardiogram, dilated ventricular cavity with a global systolic dysfunction and ejection fraction of less than 45. Normal ejection fraction is more than 50 to 75%. Management: urgent or emergent delivery in the case of advanced heart failure for hemodynamic instability. The clinical features of peripartum cardiomyopathy: onset of heart failure during last month of pregnancy or within 5 months following delivery. Left ventricular systolic dysfunction with left ventricular ejection fraction of less than 45%. Absence of other causes of heart failure and absence of heart disease prior to the final month of pregnancy. Alcoholic Cardiomyopathy. It is dilated cardiomyopathy due to heavy alcohol consumption. Features are macrocytic anemia, thrombocytopenia, and more than 2 to 1 ratio of AST to ALT. It must be present for alcoholic cardiomyopathy. Management is abstinence from alcohol. This intervention leads to reversal or normalization of left ventricular function over time. Then we have anaphylaxis. So the triggers for anaphylaxis can be food like nuts or shellfish, medications like beta-lactam antibiotics, and insect stings. The clinical features are cardiovascular, leads to vasodilation, hypotension, and tissue edema, and tachycardia. The respiratory manifestations include upper airway edema, stridor and hoarseness, bronchospasm that leads to wheezing, cutaneous like urticarial rash, pruritus, and flushing, gastrointestinal including nausea, vomiting, and abdominal pain, and treatment is with intramuscular epinephrine, airway management, and volume resuscitation, adjunctive therapy, for example, antihistamines and glucocorticoids. So, what is the diagnostic criteria for anaphylaxis? Anaphylaxis is likely if there is rapid symptom onset and any one of the following criteria, like rapid or symptom onset and one of the three criteria must be present. Number one is skin mucosa involvement like hives, lip or tongue swelling, and either hypotension or respiratory distress. Number two is involvement of more than two organ system after exposure to a likely allergen, like skin mucosa with hives, lip tongue swelling, respiratory system with wheezing, stridor, and dyspnea, cardiovascular system with hypotension, tachycardia, and syncope, and gastrointestinal symptom with abdominal pain and vomiting and diarrhea. So these four systems, like skin, respiratory system, cardiovascular, and gastrointestinal, these must be more than two. Must be involved in hypotension after exposure to a non-allergen. So, like hypotension and skin, and again this one. So one of these must be present with rapid onset of symptoms. At a question where there is no respiratory symptom, so don't expect all symptoms to be present, even just hypotension is enough. Then diagnostic challenges in anaphylaxis. Non-classic presentation, no prior allergic reaction like first episode, absence of hypotension, respiratory system or cutaneous signs, protracted or biphasic presentation. Challenging clinical situation, pre-existing condition with similar symptoms like asthma and COPD, ongoing physiologic shifts like childbirth and hemodialysis, and impaired communication, sedation, severe psychiatric illness. Medication effects directly activate the mast cells, for example, opiates and NSAIDs, interfere with epinephrine effect, for example, beta blockers and alpha adrenergic blockers. The clinical features of anaphylaxis. We are having to talk about that. Okay, so cutaneous and mucosal involvement, ocular, periorbital swelling, injected conjunctiva and tearing, oral mucosa, swelling, tingling or itching of tongue and lips, and metallic taste. Skin will lead to urticaria, flushing, and pruritus. The respiratory symptoms in the nose, congestion, and rhinorrhea will be present. Upper airway present with edema and hoarseness and stridor, and lower airway will have bronchospasm, wheezing, dyspnea, and tachypnea. The cardiovascular system will show vasodilation that will lead to hypotension, lightheadedness, and syncope and tachycardia, cardiac dysfunction, cardiac arrest. Gastrointestinal involvement, nausea, vomiting, abdominal pain, and diarrhea. And the neurologic manifestation, headache, confusion, anxiety, feeling of impending doom. Management of anaphylaxis, the immediate management. Firstly, epinephrine is the most important. Intramuscular is preferred and may be repeated, for example, 3 doses. IV in severe refractory cases. IV crystalloid and Trendelenburg position for the hypotension. Albuterol for the bronchospasm. Early intubation for upper airway obstruction. Adjunct management, H1, H2 antihistamines, glucocorticoids, glucagon for the patient on the beta blocker, reversal, hospital admission for severe initial presentation, for example, shock or ongoing symptoms despite treatment. Cholesterol crystal embolism. Livedo reticularis is seen in the patient with a cholesterol and crystal embolism. It is a reticular erythematous or purple discoloration of the skin, as you can see in this picture. It blanches on pressure and it is seen bilaterally due to the embolization to the vessels. The clinical manifestations can be immediate or delayed more than 30 days after inciting event. Blue toe syndrome, that is cyanotic toe with intact pulses. Livedo reticularis, gangrene, ulcers, Hollenhorst plaques, bright yellow refractile plaques in the retinal artery, which indicate a proximal source such as internal carotid artery. Renal dysfunction, This may persist beyond 2 weeks compared to the contrast nephropathy, which usually resolves within 1 week. On lab investigation, eosinophilia and eosinophiluria due to interleukin 5 activation, hypocomplementemia due to neutrophil activation. Treatment is supportive with statin therapy. Differentials contrast-induced nephropathy. Urinalysis will show muddy brown granular and epithelial cell cast. It resolves within 3 to 5 days. Crescentic glomerulonephritis, that is also a differential of libido reticularis. So, rapid onset of renal failure, and it is accompanied by active urinary sediment with hematuria and red cell casts. So, eosinophilia, self-made mnemonic. Remember this, NKPD. So, NK, A is for Addison's, and AIN. N is for neoplasm. C is for, what is it? I don't know. AN, autoimmune something. Okay. C is for collagenous vas what? Collagenous vascular disorders like SLE, scleroderma, cholesterol embolism. A is for allergies, asthma, parasites, drugs like allopurinol sulfa, and anticonvulsant. What do they do? They cause eosinophilia. I think so. Uh, yeah, they cause eosinophilia. So moving forward, cholesterol crystal embolism or atheroembolism. The risk factors are comorbid conditions like hypercholesterolemia, hypertension, type 2 diabetes mellitus, cardiac catheterization or vascular procedure. The clinical features are dermatologic like libido reticularis, ulcers, gangrene, blue toe syndrome, renal acute or subacute kidney disease, central nervous system like stroke and amaurosis fugax, ocular involvement like pollen host plaques, and gastrointestinal like intestinal ischemia and pancreatitis. Diagnosis is made by lab finding elevated serum creatinine, eosinophilia, and hypocomplementemia. On urinalysis, typically benign with few cells cast may have eosinophiluria. Skin or renal biopsy, biconvex needle-shaped clefts within the occluded vessels, and perivascular inflammation with the eosinophils. So, okay. Then we have fat embolism syndrome, etiology, fracture of marrow-containing bone like femur, orthopedic surgery, and pancreatitis. The clinical presentation include 24 to 72 hours following inciting event, and the clinical triad of respiratory distress, neurologic dysfunction, confusion, and petechial rash will be present. Diagnosis is based on the clinical presentation, and prevention and treatment is early immobilization of the fracture, supportive care, for example, mechanical ventilation. First degree AV block. Now, in first degree AV block, the problem is that the AV node is conducting slowly, so the PR interval, although it is fixed, but it is prolonged. So it occurs due to slow conduction through the AV node. Prolonged PR interval, P waves always follow the QRS, unlike other heart blocks. So for every QRS complex, there will be one P wave. So there is a 1-to-1 ratio between P waves and QRS complexes. So PR interval is more than 0.2 seconds, greater than 5 small boxes. Okay. It is a benign finding. Features include increased PR interval. QRS can be normal or abnormal depending on the location of the lesion. The QRS is normal if the lesion is above the AV node. QRS is abnormal if the lesion is below the AV node. It is associated with increased risk of heart failure, atrial fibrillation, and overall mortality. Management for the normal QRS, you can do the observation. If the QRS is abnormal, electrophysiological testing can be done. So in Morbid's type 1, there was type 1 AV block. Now we're talking about type 2 AV block. Type 2 AV block is subdivided into Morbid type 1 and Morbid's type 2. In Morbid's type 1, the thing is that there is a progressive PR prolongation until a beat is dropped. While in Morbid's type 2, the problem is that PR interval is fixed, but after certain intervals, the beat is dropped for some reason. And Morbid's type 2 is more dangerous. So here you can see that non-conducted P waves with a dropped beat is present at this point. So progressive lengthening of the PR interval before a dropped beat, a dropped QRS complex. Features, there is a consistent P to P interval. Increasing P, so there is also an interesting thing that the P to P interval is consistent. Then increasing PR interval, it is best appreciated by measuring the PR interval just before and after the dropped QRS complexes. Decreased RR interval, group beating, that is repeating clusters of beats followed by a dropped QRS. Treatment is observation in asymptomatic patients and correction of reversible causes like holding medications that affect the AV nodal conduction. In Morbid's type 2, here you can see that Non-conducting P waves are present, PR interval remains constant, and there is a constant RR interval, and then there is a drop beat. So it is a table about atrioventricular block. The first degree is asymptomatic. ECG finding will show PR interval prolongation, and the management is basically observation. In Morbid's type 1 and the second degree Morbid's type 1, the presentation is usually asymptomatic. ECG finding will show progressive PR interval lengthening followed by dropped QRS complex, and management is observation. Rarely, permanent pacemaker placement can also be done. Morbid type 2 second degree, the clinical presentation is fatigue, lightheadedness, and syncope. ECG features constant PR interval with randomly dropped QRS complexes, and management is permanent pacemaker placement. Third degree of complete atrioventricular block, the clinical presentation is fatigue, lightheadedness, and syncope. ECG features complete dissociation of P waves and QRS complexes, and management is permanent pacemaker placement. This is Morbid's type 1 versus Morbid's type 2. I think we should stop here, and we will have a short next session. Until next time, Allah Hafiz, fi amanillah, and take care.